basic pharmacokinetic concepts, including elimination rate, constant, volume of distribution, clearance, and bioavailability. Then we'll discuss some issues pertaining to drug concentration sampling and interpretation. And we will also discuss specific pharmacokinetic characteristics of some commonly used therapeutic agents like aminoglycosides, phenytoin, digoxin. And lastly, we'll also discuss pharmacokinetic alterations in patients with some renal and hepatic impairment. So for today's meeting, our agenda will be to discuss basics of pharmacokinetics, which is absorption, distribution, metabolism, and excretion. Then we will also discuss some basic pharmacokinetic relationships and some formulas. And then we discuss non-linear pharmacokinetics. We'll touch non-compartmental pharmacokinetics. Then we will discuss some issues pertaining to data collection and analysis. We will also discuss pharmacokinetics in renal and hepatic disease. Then we'll also touch pharmacodynamics and pharmacogenomics. So pharmacokinetics, I know this is not a very interesting topic, but from my point of view, it is the most important topic for us as pharmacists to champion, because it's not a physician's job or a nurse's job to determine the dose or dosing interval or loading doses. This is our job. And so I think this is very important for us to have a strong fundamental knowledge of this topic. So we'll just discuss some basics, which we have already studied in our pharmacy school. So what is pharmacokinetics? We have heard this many times. It's the study of what body does to the drug, right? So it's basically the study of time course of absorption, distribution, metabolism, excretion of drugs, and their corresponding pharmacological response. Okay, so in our daily practice, where is this pharmacokinetics applied, right? So dosage alterations based on physiological and pathological processes. As we all know that standard doses of a drug is determined in healthy volunteers in clinical trials. And that doesn't mean that that particular dose will be good for every patient. Our patients will be infants, neonates, adults, and doses for different population of patients will be different, which will be based on their physiology as well as some pathology, okay? So we need to determine the dose, we need to individualize the dose based on some physiological processes, like if the body weight, body size, and some maturation of organ systems, which affect these processes of absorption, distribution, metabolism. And in certain pathological conditions, if a patient is having some impairment in liver and or kidney disease, the doses will be different. It will not be the standard dose which is recommended for other patients. So we apply these principles of pharmacokinetics in our daily practice. Second is choosing a formulation. We also know that certain drugs, they undergo extensive first pass metabolism. And when we give them orally, they very minimum concentration will reach at the target organ, all right? So we can formulate a different formulation and we can administer those drugs through different routes which avoid that first pass metabolism. For example, sublingual formulations. So based on the principles of pharmacokinetics, we can just administer drugs through different routes. So next is the need for a loading dose. Also, certain drugs, their half-lives are very large, and a loading dose may be required for acute treatment. So this is also, we can get this from by applying the principles of pharmacokinetics. And time to reach onset of action and duration of action. This is the principles of pharmacokinetics also help us to determine how rapidly a drug will appear at the site of action and how long it will stay at the target organ. So we can just determine onset of action and duration of action by applying these principles. And the importance, by knowing the relationship between dose, drug concentration, and effects, we can maximize the therapeutic benefit and reduce toxicity by applying these principles, right? So moving on to our next slide, which is about absorption, the first process in the journey of a drug in the system. So we need to review certain concepts associated with absorption, which is first pass effect. What is first pass effect? Once we administer a drug and it's absorbed, it will not directly go to the systemic circulation. It passes through from GI tissues, it passes to the liver, and after it undergoes some metabolism, it then only after liver it moves to systemic circulation, right? So there are certain routes like buccal and rectal route which bypasses this liver, and if we want to avoid this by first pass effect, we can give certain medications by buccal or some rectal routes. Another concept we need to review in absorption is enterohepatic recirculation. What does enterohepatic recirculation mean? So once the drugs are absorbed in GI lumen and they pass through liver, some of those drugs, some drugs get excreted in bile, and they are metabolized by normal flora in GI and are reabsorbed again in the circulation. So they just pass from GI to liver, and from liver to again they will pass to GI, and then they will go to the systemic circulation, which is why it's called enterohepatic recirculation. Certain drugs which undergo this phenomena, they're expelled by gallbladder on sight, smell, or ingestion of food, right? So these are the concepts. We are already aware of these concepts. We just need to review these. And from exam point of view, I don't think there will be some questions asked from this section, but still you need to have an idea about these processes. Another concept associated with absorption is P-glycoprotein. What's P-glycoprotein? It's actually a reverse transporter, all right? It's an efflux pump that pumps drug back into GI lumen. Actually, this is a nature's defense mechanism for the absorb. If in certain conditions a patient or anyone ingests some poisonous substance, this pump will just remove these toxic substances back from lumen to the GI. It will not let it absorb. Okay, so what is important about this P-glycoprotein? There are very important clinically significant drug interactions associated with this drug transporter or a reverse transporter. And it has another important enzyme which is also present in GI lumen, which is CYP3A enzyme. It's also present in liver, but also present in intestine. And these two work together to decrease the absorption. All right. Dr. Rana, can you just move this? It's coming in front of my screen. I'm not able to. Yeah, I just minimized it. So most CYP3A substrates are also P-glycoprotein substrates. Okay. Many CYP3A inhibitors or inducers also inhibit P-glycoprotein, leading to increase or decrease in bioavailability. So we need to remember that this P-glycoprotein, there are many clinically significant drug interactions associated with it. And you'll just see in, I think in drug class anticoagulants, the most significant are with the drug class of anticoagulants where these interactions are clinically significant. And I think you can be tested in this exam on this concept. So we'll move to our first sample question. Okay, so we just reviewed this slide. Now there's a sample question. P-glycoprotein is a plasma protein that binds basic drugs. Or B, it transfers drug through the GI mucosa, increasing absorption. Or if it's diminishes the effect of CYP3A in the GI mucosa. Or it is an efflux pump that decreases GI mucosa. Anyone wants to try this question? You can just type your answers in the chat. Yes, absolutely. That's amazing. You just are taking attention. Okay, that's the right answer. We already reviewed it. It's an efflux pump that decreases GI mucosa absorption. Okay, the second process that drug undergoes in the body is distribution. After it's absorbed in our body, it has to get distributed all over the body fluids and tissues to reach the target organ, okay, or the site of action. And there are certain pharmacokinetic concepts associated with distribution, which are very important, like volume of distribution. What is volume of distribution? It is the apparent space in the body available to contain the drug, okay? And it's a constant that relates amount of drug in the body to an observed concentration of a drug. And we must be familiar with this equation. Volume of distribution is equal to dose and concentration. By knowing any of these, we can determine volume of distribution, all right? Another concept associated with the distribution is protein binding. Also, it affects protein binding, affects distribution of drugs. And we know, we are familiar with albumin, alpha 1 glycoprotein or lipoprotein. We in our pharmacy school, we are very well aware of this. Phenytoin is binds with albumin, and there are some clinically significant interactions which happen when more albumin, this phenytoin is bound with albumin, right? And also P-glycoprotein also affects distribution of drugs in the body. For example, P-glycoprotein is present in brain. So if we need to administer medication which has its site of action is brain, so P-glycoprotein is a reverse transporter. It will decrease the bioavailability because it's an efflux pump. It pumps out the drug back, right? So next slide we have is about clearance. So we are done with absorption, distribution, now clearance. What is clearance? What do we mean by clearance? It's defined as the volume of plasma completely emptied of drug per unit of time, right? The main pharmacokinetic parameter describing elimination is clearance. And this rate of elimination is directly proportional to the plasma concentration. So once we administer a drug, it undergoes metabolism and renal excretion at the same time, right? And more the plasma concentration is, rate of elimination is also more. And there are two main sites of elimination, which is liver, where the metabolism of drugs occur, and renal excretion, right? So it's clear from the above equation, as the plasma concentration changes, so will the rate of elimination, all right? And when the rate of administration is equal to the rate of elimination, we say the drug is in steady state. For example, on single dosing, if we give a single dose of a drug, after some time, eventually all the drug will be eliminated from the body. But in multiple dosing regimens, which we commonly encounter in our practice, rate of administration, when these two processes are in equilibrium, rate of administration and rate of elimination, we say that drug is in its steady state, right? Which is our goal, so that the drug will keep continue doing its action on the target organ, right? Now moving on to the next slide, it's clearance. Okay, there are two important pharmacokinetic parameters associated with clearance, which is elimination rate constant K, which is a fraction of amount of the drug in body eliminated per unit time. And there are two ways to estimate K. It's either by estimating half-life or either by substituting two different concentrations taken at two different times and applying natural logs to them, okay? So we can estimate the rate of elimination by these two equations, which are very important from the point of exam point of view, okay? And what is half-life? Half-life is the time it takes for the plasma concentration to decay to half of the initial concentration. Moving on to the next slide. So we already discussed that liver is the main organ responsible for the metabolism, and which part of liver is associated? These are the enzymes which are associated with drug metabolism, And there are lots of enzymes which are responsible for drug metabolism, like oxygenases, hydrolytic and conjugating enzymes. They are a lot of, it's listed in your study material, which will be shared by giving back to pharmacy in Pakistan at the end of this presentation. And also for clearance, drug transport proteins are also important to just, if you can review those, they are given, the list is given in the study material, like SLC and ABC superfamilies. Now talking about clearance, cytochrome P450 is the most important enzyme group associated with metabolism, and it's a group of heme-containing enzymes responsible for phase 1 metabolic reactions, which we have already learned in our pharmacy schools. And where are these located? These are located primarily in endoplasmic reticulum, liver, small intestine, brain, lung, and kidney, right? So certain drugs have affinity for one particular cytochrome enzyme, but most drugs have very secondary pathways. For example, cimetidine or HIV protease drugs, they are affected by or metabolized by more than one enzyme. Right. Moving to, I think there is something, Dr. Rana, can you please mute the audiences? Yeah, there is now moving on to the next slide about clearance. We have already learned about the phenomena of drug induction or drug inhibition, which can give rise to a number of clinically significant drug interactions, right? And most inducers and some inhibitors can affect more than one isoenzyme. For example, these the drugs mentioned in this slide, they affect more than one CYP3 enzyme, all right? And thus they give rise to complex drug interactions. Which are these drugs? Cimetidine, retinol, fluoxetine, and erythromycin, right? Inhibitors may affect different isoenzymes at different dosage. This is another phenomena which may be tested in your exam. For example, fluconazole, it inhibits CYP2C9, right? At dosages 100 milligram per day. But if we increase in certain pathological conditions, if we give doses more than 400 milligram per day or greater, it inhibits CYP3A4 enzyme also. So this phenomena you need to remember. Maybe you will be tested on this concept. Now moving to our first patient case. HR is receiving a vancomycin for MRSA, and HR has renal failure, all right? Pay attention to this because we will just apply some math and some formulas in this patient case. Okay, 1 gram is given on day 1 of treatment at 1200 hours. And after 2 hours of first dose, concentration is taken, which is found to be 23.8 milligrams per liter. And after 3 days of the first dose, another concentration is taken at 1400 hours, which is equal to 12.1 milligrams per liter. All right. If you were to give a 1 gram dose on day 3, okay, you will wait 3 days and then you will give the next dose, the second dose of treatment at 1600 hours. When would you need to give the next dose at a target concentration of 10 milligrams per liter? Any answers? Can you just try to solve this question? Anyone? All right, let's see if we can, how we can solve this question, all right? So HR is receiving vancomycin for MRSA and has renal failure and is given 1 gram of vancomycin on day 1st, and this is the concentration. First, we'll discuss about some basic pharmacokinetic relationships, then we will come back to this question. Okay, we already discussed volume of distribution, an important pharmacokinetic parameter. What is it? It relates the amount of drug in the body to the concentration of drug in the blood or plasma, right? It's a very familiar formula in the pharmacokinetics. V is equal to amount of drug in the body over concentration. So our concentration, we can substitute the values in this equation and we can get volume of distribution for this kind of drug, okay? So we have already given 1 gram is amount of drug, and this is the concentration, 23 on the initial concentration after giving the dose, right? So we will substitute these values here and we'll get 42 liters. When we substitute these values in this equation, we'll get volume of distribution will be estimated as 42 liters, right? Another important equation, pharmacokinetic relationship, is elimination rate constant. We already discussed this one also, that elimination rate constant can be estimated by 2 ways, either by this equation where we apply natural logs to change in concentration over a period of time from time 1 to time 2, right? Okay, or we can estimate it by applying it on in half-life equation, which is T half is equal to 0.693 over K. We can, by knowing the half-life, we can estimate the elimination rate constant. Let's try to apply these values which are given in the question in this equation, and we'll see what the value will we get, okay? So elimination rate constant, where we apply, we are given 23.8 milligram natural log of this minus natural log of the second concentration, which we take after 3 days. And this is the time difference. We take it after 3 days, right? Which is 72 hours. And it will give us the value of 0.094 per hour, right? Moving on to the next slide. All right, so on day 3, sorry, we give another gram. On day 1st, we give 1 gram. And on day 3, we are giving another gram to this patient, okay? So what will be the concentration or initial concentration on day 3? So we'll estimate, we'll give 1 gram, and this is the volume of distribution which we estimated earlier. And it will give us same concentration, 23.8 milligram per liter, right? But when we give the second dose on day 3, we have still remaining, how much we have remaining? It's the concentration is 12.1 milligram. And then this is the concentration we estimate on day 3, right? And once we give the new dose, next dose, it will give rise to increase in concentration by about 23.8 milligrams per liter. So it will be added, which is the drug, which is known as drug accumulation. So this is the concentration which we will have on the 3rd day, right? 36 milligram per liter. So we can solve this equation either by applying another important equation, which is C naught is equal to C1 multiplied by E minus KT. This equation is also very, very common equation in pharmacokinetics. So this is our target concentration, and we just substitute the values here, and we get a T half of 136 hours or 6 days. I will show you another way how to estimate this question, how to answer this question. It's pretty much simple. I'll just go back to the question. Okay, so if you get this sort of question in the exam, you just have to pay attention to certain values given in the question first, okay? See, this shows that on giving the 1st gram on 1st day of the treatment, the initial concentration is, okay, 23.8 milligrams per liter. If you closely pay attention, on day 3, it falls absolutely half of what was the initial concentration, exactly like 20, almost 24, and then it falls to 12, which is exactly the half the concentration. So what does that mean? We are giving after 3 days of time, the initial concentration falls to half of the concentration, which means its half-life is 3 days, okay? Now the examiner asks us to, if we want to get a target concentration of 10 milligrams. Okay, on day 3, we give another gram, which will result in a concentration of 36 milligrams in this patient. So what is the half of 36 milligrams? So in one half-life, the concentration will go down to 18 milligrams, which is half of the concentration, initial concentration. So in 3 days, the concentration will fall to 18 milligrams. And in another 3 days, it will fall to 9 milligrams, which is exactly 6 days. So the right answer is, if you were to give 1 gram dose on day 3, we will have to wait 6 days from the dose on day 3, right? Another question we will discuss, it's pretty much simple. Following 100 milligram of drug IV by given IV route and 200 milligrams of the same drug per oral, the area under curves are 50 milligram per liter per hour and 25 milligram per liter per hour. What is the bioavailability? And this is another important equation we need to remember. What is bioavailability? It's defined as the fraction of unchanged drug reaching the systemic circulation following administration by any route, right? So this is the equation you need to memorize, and you can be tested on this concept and equation, okay? So we are given the values, we'll simply substitute these values in this formula, and we'll get 25%. So what is the right answer? 25%. Okay. Moving on to the next patient case. All right. So CM is a 55-year-old male initiated on phenytoin 200 milligrams daily after craniotomy. Okay. His current steady state is 66 milligrams per liter. If his affinity constant is calculated to be 5 milligram per liter, what is most likely to occur if his dosage is doubled? Okay, his concentration will double because phenytoin clearance is linear above the Km. His concentration will be more than double because phenytoin clearance is nonlinear above the Km. His concentration will stay the same because phenytoin is an auto-inducer and clearance increases with time. His concentration will increase by only 50% because phenytoin absorption decreases significantly with dosages greater than 300 milligrams. Anyone wants to answer this question? C, D. All right, some right answers there, which is a good thing that you have good knowledge of pharmacokinetics. Okay. Anyone can try, just try. And if anyone knows more about this kinetics, just you can add more on the phenytoin kinetics. Okay, let's see what will be the right answer. Let's first discuss nonlinear pharmacokinetics. Usually all drugs which we encounter in our clinical practice, they follow linear kinetics. What's meant by linear kinetics or linear elimination? That they follow first order elimination, which means their elimination pathway is not saturable at the doses we encounter in our clinical practice, all right? But there are some drugs which do not follow linear kinetics, and the elimination pathway is saturable. For example, if we give doses that are therapeutic doses, their elimination pathway is saturable at that doses, and this rate of elimination will not follow first order kinetics. What does that mean? That means rate of elimination will not be directly proportional to the plasma concentration, as it is true for the other drugs, where a rate of elimination is directly proportional to the plasma concentration, right? So what is it known as? It's known as, this sort of kinetics is also known as nonlinear pharmacokinetics, or saturation or partial saturation of the elimination pathway, or Michaelis-Menten equation, which is this modified equation for the rate of elimination in case of these drugs, which is Vmax multiplied by plasma concentration divided by Km plus C, where Vmax is the maximum elimination capacity and Km is the concentration at which Vmax is 50%. Okay, so we have an important thing to remember in this sort of kinetics. Non-linearity occurs when concentration is at or above Km. So in our previous case, we will see what is the given value. Our plasma concentration is 6 milligrams, but what is the affinity constant? It's 5. So his plasma concentration is above Km. So this will not follow linear kinetics. What does that mean? If we increase the dosage, it will not double, simply double. It can double more than, it will be more than double, or it can triple or quadruple. Because elimination pathway is saturated, there is no elimination occurring, only we are adding more doses, which can give rise to significant plasma concentration, right? So the right answer will be, his concentration will be more than double, because phantom clearance is non-linear above the Km, all right? So now moving to our next section, that's data collection and analysis. We must be encountering these sampling or issues in our daily practice, or may not if you are working in a community, but we just need to know about these, all right? So what is important in data collection and analysis? Timing is important. As we already learned that first, when we administer a drug, we have to give time to complete the absorption and distribution phases. If we give a drug and just after only short period of time, say 10 minutes, we take samples to estimate the levels of this drug, it will give us erroneous results, because we did not give time to absorption and distribution phases to complete. So it's very important to know when to sample, when to check the plasma concentrations. And in the case of certain drugs, which, for example, digoxin and lithium, they take a lot of time for these processes to complete, like absorption and distribution. And we cannot sample, we cannot estimate the plasma concentration of such drugs before 6 hours or just before the next dose, when the next dose is scheduled. Okay, so we need to remember this. It's a very important thing to remember in this topic, data collection and analysis. So timing is very important. Another important thing in hemodialysis, also we need to ensure complete redistribution of dialysis. If we want to estimate the levels of drug, we need to ensure complete redistribution, okay? So we need to take care of this thing in our minds, that timing is very important. And there are certain specimen requirements also for certain drugs. What are those? For estimation of certain drugs, we need whole blood. For example, cyclosporine, amiodarone, and some drugs need to be estimated in plasma, and certain drugs need to be estimated in serum. So we need to remember these specific requirements for certain drugs. Moving on to the next slide, it's a sample question. A drug assay is, okay, you can try this, just pay attention and try to answer this question. A drug assay is touted as having high specificity but low sensitivity. Which statement best describes what this means? Okay. The options are: the assay cannot distinguish the drug from like products, but cannot detect extremely low concentrations. The assay cannot distinguish the drug from like products, but can detect extremely low concentrations. The assay can distinguish the drug from like products and can detect extremely low concentrations. The assay can distinguish the drug from like products, but cannot detect extremely low concentrations. What do you think will be the right answer? You can try. Oh, all right, all of you know this concept, so I not need to emphasize more. Very nice. Everybody is answering perfectly. Thank you. That's the right answer. D is the right answer. Okay, so you already are aware of this concept. Assay terminology: precision, accuracy, predictive performance, sensitivity, and specificity. So what is precision? or reproducibility. It's an ability of an assay to give the same results over and over again. Say, for example, an assay gives a result of 10 milligrams per liter of a drug concentration. If we do it again and again, if the result comes same, then we can say that it's precise. This assay is precise. And what's accuracy? Accuracy is, for example, if we give a drug and we expect that the concentration should be 5 milligrams per liter, okay? And when we estimate or when we sample this and check in the levels in the plasma, and it comes out to be 5 milligrams per liter, then we can say that this assay is highly accurate, okay? Predictive performance is also measure of accuracy. It's used in literature. And sensitivity is the ability of an assay to detect very low levels of a drug, okay? And specificity is the ability of an assay to detect the drug from the like substances. For example, ability of an assay to detect aminoglycosides like amikacin and gentamicin. It can just detect different, same structurally similar drugs from the other. All right. So the right answer is D. Another thing we want to discuss about data collection and analysis is assay methodology. Okay, so immunoassays, these are usually the three methods are used in assays. So which are these? Immunoassays, enzyme immunoassays, and fluorescence immunoassays. There is a much detail given in your study material. You can just go through, it's pretty much straightforward. There is nothing important in it. Okay, so moving on to our next case. Patient KM is an 80-year-old woman, and she has a weight of 52 kilograms and her height is 5 feet 4 inches. She is admitted for pyelonephritis with sepsis, all right? Her past medical history is she had myocardial infarction twice. She has chronic heart failure. She has hypertension, osteoporosis. She has rheumatoid arthritis, and she has cardiovascular accident. Okay, her labs are this. Her serum creatinine is 0.2 milligram per deciliter. Her albumin is 2.9 gram per deciliter, and she's on these drugs: trimethoprim sulfa, lisinopril, digoxin, furosemide, cimetidine, and Tylenol, and calcium carbonate, and carvedilol. All right, pretty much complex drug regimen. So what is the question asking about this case? What is the best assessment of KM's renal dysfunction or renal function? Her serum creatinine is in the normal range and no dosage adjustments are necessary. Because of her age, KM has certain degree of renal dysfunction and doses may need to be adjusted. Because of pyelonephritis, KM has renal dysfunction and doses may need to be adjusted. Her serum creatinine is in the normal range, but her BUN is elevated, so doses may need to be adjusted. What do you guys think? Yeah, you can keep just. A, everybody's writing A, okay. B, all right. So number of responses. In sepsis, high dose, okay. Somebody's writing in, okay, A. Okay. Okay, let's find out. Let's find out now what will be the right answer. Another question asked about KM is which of the KM's drugs, because she's on very complex regimen, we need to also watch for that. Which of the KM's drugs may alter serum creatinine concentrations? Is it lisinopril or digoxin? Is it trimethoprim sulfamethoxazole and cimetidine? Is it furosemide and calcium carbonate? Is it acetaminophen or carvedilol? Any guesses? A. Somebody's writing A. Okay. There's no problem. It's good if you're trying to answer. Okay, A. Okay, let's find out. So, pharmacokinetics in renal disease. How do we estimate kidney function? Normally, we must be aware that we estimate kidney function by creatinine clearance or by GFR estimation. Okay, so what we do, creatinine production and elimination is used as an important biomarker for the estimation of kidney function. How is it calculated? It's calculated by collecting 24-hour urine and then estimating the creatinine levels. Then we can ultimately substitute this creatinine value in the equations or by many many of the equations which are used to estimate the creatinine clearance, like Jellyfy, Cockcroft, Galt, which is the most important equation. And another, these all equations are listed in your study material. And GFR estimated, how we do this GFR estimation, we can do these by these equations, MDRD study equation or CKD EPI equation. These are all equations are listed in your study material, and you can just memorize this. But from exam point of view, I will recommend to memorize this one most importantly, which is Cockcroft-Galt equation. All right, so let's learn about PK in renal disease and know the factors influencing estimates of creatinine. Okay, we know how to estimate creatinine, but we must be aware also of the factors that influence the estimates of creatinine, okay, which are certain disease states and clinical conditions, and also body mass and muscle mass and diet and drugs and endogenous substances. For example, we have already seen this question about the drugs. So there are certain drugs which are mentioned in detail in your study material, which you need to memorize. There is no other way. You just need to memorize which drugs affect the estimates of creatinine clearance. Okay, you just go through that study material and just try to memorize those drugs. And laboratory interaction also and pharmacokinetic interaction also affects the estimates of creatinine clearance. So how do we dose in renal disease? For loading doses, there is not pretty much changes in the loading doses, but maintenance doses need to be changed, of course, adjusted in the patients having renal disease, either by changing dosing interval or reducing the dose. Definitely, if a patient is having extensive renal dysfunction, the doses will be very lower than the standard doses, right? So let's go back to our patient case and estimate her creatinine clearance and see how much it is. So this is the equation you need to memorize: 140 minus 8 into body weight, or serum creatinine value into 72. If she is a female, for females, we multiply by this unit 0.85%. Why is that? For females, the creatinine production is lesser than males, okay, by 15%. So this value is added as a correction factor. So once we substitute her age, we know her age, she's 80 years old. We know her weight, 52 kilos, and we know her serum creatinine. Once we substitute those values in this equation, it comes out to be 42 mils per minute, which actually shows renal dysfunction. And drugs dosing needs to be adjusted if there is the creatinine clearance is less than 50. You will study this in your nephrology chapter about the renal dysfunctions and its categories, and you'll just have to memorize this there. So for her, which is the best assessment of KM's renal function, since we saw that because of her age, KM will have certain degree of renal dysfunction, and definitely doses may need to be adjusted. Also, another point I want to mention to you, since she's 80 years old, it's known that once we cross 30 years old, we lose one point in GFR. Okay, so everybody just loses renal function by one 1% every year of the age. Since she's 80, so she will be definitely having some extensive renal dysfunction. And we also estimated by applying the Cockcroft-Gault equation, and we found out it's very low. So her dosage may need to be adjusted. So this is the right answer. So moving on to the next question, which is which of the KM's drugs may alter serum creatinine concentrations? So this is listed in your study material: trimethoprim and sulfamethoxazole and cimetidine. They are known to alter serum creatinine concentration. So we need to memorize about these drugs. They can, so if a patient of yours is going for some labs on serum creatinine, you need to just look for these drugs, okay? So moving to our next patient case. SJ is a 50-year-old male with fungemia. He has past medical history of hepatic dysfunction. She has ascites. There is no encephalopathy. And he started on caspofungin. And caspofungin, there is a recommendation, dosing recommendation written in the leaflet, that we need to decrease the dose in patients with Child-Pugh score of 7 to 9, okay? There are labs given in this patient case, and just we'll see what the examiner is asking us. So what is his Child-Pugh scores? We need to estimate his Child-Pugh score. Let's see how we can estimate it. If anybody knows about it, if you want the answer, you can write in the chat box. Okay. Let's see how we can estimate the Child-Pugh score. So first we will just go through the rules for dosing in hepatic disease. High extraction drugs are affected more than low extraction drugs. What do we mean by high extraction drugs? There are certain drugs which are highly metabolized in liver. Once they are administered and absorbed, once they pass in the liver, they're extensively metabolized, and these drugs are known as having high extraction ratio drugs, okay? So we should know which sort of drugs these are. High extraction drugs are obviously affected more than low extraction ratio drugs. And another rule is conjugation is pretty much maintained in liver disease. So if there is extensive hepatic impairment, then only we need to adjust the dose. Otherwise, it is conjugation enzymes, they are pretty much maintained in liver disease. And how we can start dosing in these sort of patients? We can start with low doses and increase slowly, right? So there is another table. It's Child-Pugh classification for liver disease. So this you have to memorize. So there is these are the is encephalopathy, ascites, bilirubin. If these values are given, you will just count the points here, okay? So these are the points you will just count, because we'll go back to the question and we'll see how much is the score of this patient. So he has ascites and he has no encephalopathy. Once we apply these values, the labs are given, and we have to memorize this chart. And we have to remember this. There is no other way, just you have to remember this if you want to calculate this on a exam. So there is, if we calculate and put values here, how much we will get the answer. His Child-Pugh score will be 8, because everything is given. We just need to calculate by using this table. I don't think you will be tested on this concept in exam, but still, for your information, you need to be aware of this concept. Now, moving on to pharmacodynamics. So what is pharmacodynamics? We all know this relationship between drug concentrations and the pharmacological response. Another concept you can be tested in exam is hysteresis loops. What is this? So the concentrations late after a dose produce an effect different from that produced by the same concentration after the dose. Okay, concentrations late after the dose produce an effect different from that produced by the same concentration after the dose. Why this? There are two sort of hysteresis loops, which are counterclockwise hysteresis loops. What are the causes? It's increased sensitivity or formation of an active metabolite, delay in equilibrium between plasma concentrations and concentrations at the site of action. And examples in this include digoxin. So the concentrations we know, once we administer a drug, the plasma concentration increases, and after the elimination part takes place, the plasma concentration decreases. So the same concentrations of just after the dose produces a different effect than the same concentration after the elimination takes over. Okay, so why this happens? It must be happening either due to increased sensitivity or formation of an active metabolite. There is another loop which is also important, clockwise hysteresis. And what could be the causes of this? Tolerance or formation of an inhibitory metabolite, or equilibrium reached faster between arterial blood and site of action versus venous blood and site of action. Examples include pseudoephedrine and cocaine. So this is the question which can be asked in the exam. Which is the most likely reason that a drug will follow clockwise hysteresis? Once you just go through the study material, you'll understand it's a pretty much straightforward concept. It's nothing that will not understand. So tolerance will be responsible for clockwise hysteresis. Moving on to our last section, pharmacogenomics. So for what's pharmacogenomics, it's actually the precision medicine, which we know is the future of medicine, that the response of a drug in different individuals is different. Why it is different is because there are different, there is coexistence of more than one genetic variant, which are stable components in the population. How do they affect the drug metabolism, or how do they affect the response of drugs? Population in general is divided in 4 intermediate, extensive, and ultra-rapid metabolizers. So it is a polymorphism existing for the enzymes responsible for the drug metabolism. So if a person is highly ultra-rapid metabolizer, if we administer a drug to this patient, the drug will be completely metabolized and there will be no plasma concentration that will reach to the target organ or the site of action. So it will result in the failure of therapy, right? So this does exist in certain classes of drugs like antipsychotics, statins, and I think this anticoagulants also, yeah. So there is a terminology we need to remember in this, the phenotype, as we know, expression of the trait, and genotype, genetic makeup. Actually, this is an emerging field of medicine. And in US, they are already using this pharmacogenomics in their clinical practice. And this association, Clinical Pharmacogenomics Implementation Consortium, this is an association in US which is responsible for implementing precision medicine or pharmacogenomics in the regular clinical practice. What is their role? They are designed to facilitate translation of pharmacogenomics information from research to clinical practice. Okay, so this is an emerging field, and there are lots of recommendations added every month, every day about the this pharmacogenomics. They develop guidelines for use of pharmacogenetic testing in drug dosing. Okay, so now how they are doing their clinical practice? They, before prescribing a therapy to a patient, they do the pharmacogenetic testing to see if this patient will respond to this medication therapy, right? So this is an emerging field. In US, they are already started it, and I think in Middle East also, they are trying to apply this in the clinical practice. And this is focused on specific drug gene pairs. Okay, that's all, and we'll end our presentation with certain cases. Okay, PL is a 45-year-old man with CRF and phenytoin. He's prescribed phenytoin 400 milligrams per day for seizures. His labs are phenytoin concentration, and which is given as 13.6 milligrams, and albumin concentration is 4.2 grams per deciliter. So what is the question? What do you recommend to do with his dose? So already he's on this dose 400 milligram per day for seizures. Okay. So his phenytoin concentration is given this 13.6, and his albumin is 4.2 grams per deciliter. What do you recommend to do with his dose? Make no changes in his current drug regimen. Keep the total daily dose the same, but change the regimen to 200 milligram BID. Increase the dose for better seizure control. Decrease the dose to prevent toxicity. What do you guys think? Anyone wants to try? You can just write the answers. If you remember something from your pharmacy school about albumin and phenytoin, yeah, there's a certain clinical drug interaction. B, okay. Okay, let's see what is the right answer. So everybody is writing B, keep the daily dose the same, but change the regimen. All right, let's see. So first of all, we need to remember when for this, we need to memorize this drug, particular pharmacokinetic information of particular drugs. What is the therapeutic range? 10 to 20 milligrams. So what is given in the question, it seems is pretty much in the range. It's 13.6. It's pretty much in the range, right? What is given the therapeutic range? But there is also some comments. Percentage free increases with renal failure and hypoalbuminemia. So if a patient is having less albumin in the plasma and also there is renal failure, so free drug increases. So the this therapeutic plasma concentration of that drug will increase. So just will again try to solve. And also when it comes to phenytoin, if there is hypoalbuminemia, there is an equation to get the corrected plasma concentration. So whatever seems from the estimation of our plasma concentration may not be the correct value. And if the patient has hypoalbuminemia or if the patient has renal function. And for correction of that value, we have this equation. C adjusted is equal to plasma concentration observed, and we have to substitute this correction values and substitute the value which we have in the question already, 4.2. Here we will substitute 13.6. What was the estimated plasma concentration for this patient? Once we substitute this value, because this patient is having hypoalbuminemia and also renal dysfunction, so we need to just see what is the adjusted plasma concentration. And once we substitute the values in this equation, we'll get 27 milligram per liter, which is much above the range, much above the therapeutic range. So what will be the right answer? So we need to decrease the dose. So this dose is already high because he has a hypoalbuminemia. So not all of his phenytoin will be will have protein binding with albumin. So there will be increase in free drug concentration, which can result in toxicity, right? So this is the right answer. Decrease the dose to prevent toxicity. Another pharmacokinetic information, we'll just check this last case. PP is a 34-year-old man with cerebral palsy and UTIs. He's given tobramycin 400 milligrams IV daily. This high-dose extended interval regimen takes advantage of the aminoglycosides concentration-dependent killing, is more efficacious than standard dosing, does not require concentration monitoring, will not cause nephrotoxicity. What do you guys think? This dose is pretty much high. And what do you think will be the reason? Let's review the last slide of our presentation. For aminoglycosides, if we, this is the PK information, you need to memorize this table. Okay, so for aminoglycosides, high dose extended interval or once daily dosing is generally recommended to decrease toxicity and improve efficacy. So by clinical trials, it has been estimated that high dosing or once daily dosing, it increases the efficacy and decreases toxicity. So what will be the right answer? It takes advantage of aminoglycosides concentration dependent killing. So this will be the right answer. It is given, this information is given on many other drugs in your study material. You just need to memorize these specific drugs and the pharmacokinetic information on these drugs. That is all about my presentation today. So if you have any questions, you can ask. Dr. Rana, are you there?
Yes, I am there. Just a minute.
Okay, he has certain level of hypoalbuminemia, and since he has renal, because in our question it's given that he has some renal impairment, that's why we use an equation where we have to add this. I will just go back to this slide. He has chronic renal failure, right? It's mentioned in the question that he has chronic renal failure, right? So which equation will apply to him? This equation where we have to add the albumin value, and 4.4 is usually just the exact level of albumin which is considered as normal, but in this patient it's 4.2. So we'll just add the values in this equation because this patient has chronic renal failure. That's why we will apply this equation to get the corrected concentration or adjusted concentration of plasma levels. Okay, I hope that answers your question.
Hey guys, if you have any question, you may ask.
About last show concentration depend along, but along single high dosing may reduce renal toxicity. Kindly correct me. See, it has been, what are the guidelines which we use in our clinical practice? These have been